Morning, everyone. My name is Dr. Bashir, if anybody doesn't know my name. And today I'm going to present multiple sclerosis. So this slide shows the objectives of my presentation today. First, I'm going to discuss what is multiple sclerosis, what is the pathogenesis for the disease, its epidemiology, etiology, some of the diagnostic criteria for the disease. We're going to recognize symptoms of multiple sclerosis, how to manage these patients, and then we're going to review some of the symptomatic management. So this slide tells us a little brief overview of multiple sclerosis. So what is multiple sclerosis? It's an idiopathic demyelinating disease caused by autoimmune process causing chronic inflammation affecting different parts of CNS like brain, spinal cord, or optic nerve. This immune-mediated inflammatory process affects myelinated axons, and the inflamed myelin leads to plaques or lesions and ends up destroying both myelin and axons to variable extent, leading to white matter inflammation, demyelination, glial scarring, sclerosis, producing disability due to reduced nerve conduction velocity in the demyelinated axons as compared to the myelinated axons, and that leads to ultimate impulse conduction block. 30% of the patients tend to develop disabilities in 20 to 25 years. Hallmark of the disease is symptoms that occur in different anatomic locations and are months or years apart. Multiple sclerosis is the most common cause of non-traumatic neurological disability in young people. So this slide shows the pathophysiology for MS patients. It's a T cell mediated type 4 hypersensitivity reaction. T cells are key players in multiple sclerosis. These cells enter blood-brain barrier and are inappropriately activated to recognize myelin and myelin-forming cells, that is oligodendrocytes you see here, sheathing the axon. They recognize them as foreign agents in the body, and then they start attacking them. So the inappropriate immune response can cause production of cytokines that continue to activate T cells, macrophages, and B cells. B cells make antibodies against myelin antigen. Macrophages use these antibodies to engulf the myelin and oligodendrocytes and cause additional damage to the myelin, leading further demyelination. And so what happens that this attack goes on, and after an attack, regulatory T cells will suppress the immune cells, and oligodendrocytes will remyelinate the axons, but over time the demyelination becomes irreversible and there is axonal loss. So you see the oligodendrocytes here, but then you see these immune cells. These are the T cells, B cells, and macrophages crossing the brain barrier and attacking the myelin and the whole thing. Okay. Can you see my next slide? Okay.
Yes.
Yeah, okay. Epidemiology of MS. In US, the prevalence of the disease is 58 to 95 per 100,000. And according to National Multiple Sclerosis Society, 400,000 individuals are affected by MS. Also worldwide, 2.1 million people are affected by MS. It's more common near the equator on the northern side and is rare in Black, Africans, and Asians. Female to male ratio is 2.5:1. And the peak age of onset in females is 29, whereas in males is 31 years of age. So the etiology for the disease, the exact cause is not known, but it's believed that genetically susceptible people encounter some kind of environmental trigger, like bacterial or viral infections, like EBV, cigarette smoking, and low vitamin D levels that trigger the immune response against the myelin antigen, perpetuating the disease. So the genetic and molecular factors. Concordance rate in monozygotic twins is 20 to 35% and suggests genetic factors have modest effect. First degree family members like children or siblings of patients with MS have 7-fold increased risk of developing MS, but still it's just 2.5 to 5% risk overall. In case of MS, it may be that a polymorphism in the promoter region of a gene involved in immune response would generate an exaggerated response to an antigen, leading to immune cell proliferation and autoimmunity. There's also research going on in terms of a single nucleotide polymorphism may be involved in increased risk of severe disease or certain types of MS. For example, HLA-DRP1 on chromosomal locus has been consistently associated with MS susceptibility. Also, HLA-CO5 allele confers protection against the disease. Also, molecular mimicry has been is also thought to play its part in MS, as it's thought that T cells get activated to some antigen in the periphery, and then they attack the brain proteins sharing the same epitopes. So some of the environmental factors that, as I had discussed in the previous slide, that play their role in MS pathogenesis is are low vitamin D levels, and also smoking. So many patients many MS patients are found to have low vitamin D, and there's also increased risk of relapses with low vitamin D levels. Several studies have shown that with higher levels of vitamin D, there's a reduction in the relapse rate, and also gadolinium lesions with levels greater than 40. Smoking is also related to higher likelihood of going to progressive disease and increased rate of conversion from clinically isolated syndrome to clinically definite MS. So MS diagnosis. So diagnosis is based on the symptoms, medical imaging, and lab testing. MRI brain and spinal cord shows plaques or lesions. However, these abnormalities are not specific to MS, as cerebral small vessel disease may appear similar, and some MS patients may have false negative MRI scans. Despite these drawbacks, criteria have now been developed where it is possible to diagnose MS after first attack, that is clinically isolated syndrome, on the basis of strictly defined MRI features. So then spinal tap can be done for these patients, and that will show elevated levels of WBC, but not more than 50 with the lymphocytic predominance. Proteins may be high, but usually less than 100, and 80 to 95% of the patients with clinically definite MS will have oligoclonal bands in CNF, but not in serum. And also patients with clinically isolated syndrome and positive oligoclonal bands have higher rate of conversion to clinically definite MS, which is also inclusion criteria for dissemination in time. These oligoclonal bands are not specific for MS, as can be seen in other CNS infections. For example, subacute sclerosing panencephalitis, Lyme disease, syphilis, and also in 7% of the normal individuals. Then we can also do visual evoked potential, which measure response to visual stimulus. And in this case, there will be delayed central conduction in the visual pathways as a result of previous subclinical optic neuritis. So this slide shows us the oligoclonal bands that we were discussing in the abnormal, in the patient's CSF as compared to the normal CSF. You can see here, there are no bands. So yeah, so this slide shows us the 2017 revised diagnostic criteria, RRMS. Based on this criteria, we can diagnose patients with MS. We count number of attacks and number of lesions with objective clinical evidence, and additional data may or may not be needed. For example, if you encounter a patient who had equal to or greater than 2 clinical attacks, then equal to or greater than 2 number of lesions, you do not need additional data to diagnose a patient with MS. And so yeah, based on this, you can diagnose the patient. Again, 2017 MRI criteria. So dissemination in space is demonstrated by 1 T2 lesion in at least 2 of the 4 areas of CNS. That includes periventricular, juxtacortical, cortical, infratentorial, and spinal cord. Dissemination in time can be demonstrated by new T2 lesion or gadolinium enhancing lesion on follow-up MRI with reference to baseline, irrespective of the timing of baseline MRI. Simultaneous presence of gadolinium enhancing and non-enhancing lesions at any time. So this slide shows us the MRI with enhancing lesions in periventricular region of MS patient. Yeah, so another slide showing both enhancing and non-enhancing lesions. So this slide shows us the MRI comparison of healthy brain with MS patient brain. You can see the healthy brain, and you can compare that with the brain damage in MS patient due to plaques or lesions. Okay. So this slide shows us the presenting symptoms of MS. This shows a whole lot of list of classic symptoms that you will find in MS. But the point to be noted here is that presentation of MS varies among patients. Some patients can have cognitive predominance of cognitive changes. With others, you can find prominent ataxia, hemiparesis, paraparesis, hemisensory loss, depression, visual symptoms. And additionally, it is important to recognize that the progression of physical and cognitive cognitive disability in MS may occur in the absence of clinical exacerbations. Attacks or exacerbations of multiple sclerosis are characterized by the symptoms that reflect CNS involvement. The episodes are separated in time and space. That is, episodes will occur months or years apart and affect different anatomic locations. As for example, you will encounter a patient that will come to your office with paresthesia of a hand. That will resolve, right? And the patient comes in after a few months with weakness in the leg, in one leg or anything like that, and then or visual disturbances. So in addition, these duration of attacks should be longer than 24 hours to be labeled as presenting symptom of multiple sclerosis. So here you can note that most of the patients, like they can encounter sensory loss in most cases, 70% of the time. They will present with pain, paresthesia, so these can be early symptoms. Spinal cord involvement will lead to motor or autonomic problems, cerebellar symptoms, trigeminal neuralgias, constitutional symptoms, and mostly fatigue. 70% of the cases will have fatigue. They can have pain, they can have psychiatric problems, they can have depression in 60% of the patients. So yeah, so you have to keep in mind. So optic neuritis is presenting symptom of multiple sclerosis in 13% of the patients, sorry, and is common during course of multiple sclerosis in 50% of the time of the patients. 90% of these patients with optic neuritis will have pain with eye movement. Also, monocular visual loss or blurring will be seen, central blind spot or scotoma, loss of color vision, poor visual acuity or getting worse than baseline, and afferent pupillary defect. These things will be present in the patient who's encountering optic neuritis. So treatment for these patients who only have optic neuritis and no other neurological symptom is IV steroids, and all patients should get MRI at the time of presentation. So swinging flashlight task for optic neuritis examination. For this, you have to ask the patient to focus on a distant target in a dark room. Pupils will get dilated, and then you show the bright torch on the normal eye, which is right eye in this slide. That will start the direct and consensual pupillary constriction. Now you move the torch to the abnormal left eye. And in that case, you will see the paradoxical dilation that shows that the efferent pathway of light reflex is not working. To elicit this, one might need to swing the torch back and forth several times. So differential diagnosis, when a patient presents with symptoms resembling the symptoms of multiple sclerosis, we should be aware of these differentials that we see in the list, and we should be able to exclude them by a proper history taking and appropriate investigation. So patterns of multiple sclerosis, we have 4 different patterns for multiple sclerosis course. So they include relapsing remitting multiple sclerosis, secondary progressive multiple sclerosis, primary progressive multiple sclerosis, and progressive relapsing multiple sclerosis. So you can see how the disease course will be for the patient with the relapses. In case of relapsing remitting, you have the relapses and then remission and so on and so forth. So clinically isolated syndrome, clinically isolated disease means, or syndrome means, first unifocal or multifocal neurological episode lasting more than 24 hours due to inflammatory or demyelinating lesions of CNS. Patients who have more than 2 lesions on T2 MRI are more prone to progress to clinically definite MS as compared to patients with normal MRI. So treatment summary, treatment should be targeted toward relieving symptoms, treating acute exacerbations, shortening the duration of an acute relapse and reducing the frequency of these relapses, and disease progression prevention. Drugs that reduce the frequency of exacerbation or slow progression are referred to as disease modifying drugs. They can be further classified as immunomodulating or immunosuppressive drugs. Some of these immunosuppressants are also FDA approved as antineoplastic agents. Drugs that do not modify the course of the disease but treat MS-related symptoms, for example, acute exacerbations, cognitive dysfunction, spasticity, bowel and bladder problems, fatigue, they are referred to as symptom management medications. So treatment of acute MS flare. Acute exacerbations are treated with steroids, per oral methylprednisolone for milder exacerbations, 1 gram IV methylprednisolone or prednisone per oral, 1250 mg per day for 3 to 5 days if more severe, or for optic neuritis patients. If very severe, we can do plasma exchange for these patients. So disease-modifying therapies, under this we have several drugs. To name a few, we have interferon beta 1A and 1B, glatiramer, natalizumab. They all have different mechanism of action, but the prime thing is that they modify the immune response against myelin, and they differ in efficacy in terms of a reduction in terms of relapse reduction rate. So these are the same disease-modifying therapies that we had seen in the previous slide and their main side effects. So interferon beta 1A and beta 1B have the same side effects like injection site reactions, flu-like complex, and elevation of LFTs. Glatiramer, again, injection site reaction, vasodilation, chest pain, and most of these drugs are category C drugs for pregnant women, but this is category B, glatiramer. So natalizumab will cause headache, infusion site reaction, leukocytosis, PML, elevation of LFTs, fingolimod, bradycardia with first dose, macular edema, liver toxicity, and so on and so forth. And the list, we have so many drugs, so I won't go through all of them. Okay, so symptomatic treatment for these patients. So as we had seen in the previous slide, that these patients are going to encounter a wide range of symptoms. So if they present with cognition problems, which is the most one of the most common problem that they encounter, drugs like donepezil, memantidine do not benefit these patients. We can offer them brain games, behavior modifications like lists, reminders can be helpful. Tremors can be disabling, so we can treat tremors with propranolol, primidone, wrist weights, and assistive devices. Ataxia, again, very disabling, and gait training assisted devices, and FDA-approved drug dalfampridine can be used, but it is contraindicated in patients with a history of seizure. Fatigue can be treated with modafinil, amantadine, stimulant, but first you have to make sure that the patient is getting enough and adequate sleep. Treat any underlying depression. Then bladder dysfunction, antispasmodic like tolteridone, oxybutynin can be used for these patients. Spasticity, baclofen, dantrolene can be used, and upper limb spasticity. We can use botulinum, alpha-2 agonist like tizanidine, and second-line drug is benzopene, for example, diazepam. So that concludes my presentation. Thank you for listening to me patiently, because I know how boring it can be. I really hope you guys liked it. Thank you.